number 4, I asked you to do not the entire thing, just a few activities, but one of the activities was activity 1, and in that activity, we were injecting 3 different kinds of rats. There was a group that was normal. There was a group that had its thyroid removed, that means a thyroidectomy. And then there was a group of rats that had its anterior pituitary removed, and that means they were hypophysectomized. A phenomenon that I see on the lab exam when I use hypophysectomized on the lab exam, students start to read that word, and for whatever reason, their brain immediately thinks that those rats had their hypothalamus removed. That is not compatible with life. Can't remove the hypothalamus and live, but you can remove the anterior pituitary. So don't let your brain start to pre-read a word and then make an illogical jump. Tomorrow on the exam, you're going to be stressed, you're going to be anxious. You're allowed to write on the exam, and I encourage you to slow yourself down and circle any key words or highlight them with a highlighter pen. Do something to draw your attention to key terms. Most of the time, I do that for you when I write the exam. I'll highlight a word or underline it or put it in bold, but in some way I'm trying to capture your attention to the word. So the purpose of this activity was to show how we could replace missing hormones for the 2 rats that had been surgically modified. The important first step was, of course, to take a preliminary, a baseline read of their metabolic rates. You do not need to memorize the calculations that we did to calculate their metabolic rate. You do not need to do that. But you should be able to talk through your data. The normal rat had a higher metabolic rate than the other 2 rats. Why? Their HPT pathway was compromised. They did not make thyroxine T4 and T3, either because they didn't have a thyroid gland, or in the case of the hypophysectomized rat, they didn't have the signaling molecule TSH to stimulate the thyroid gland. Then in the next experiment, once we got the baseline read, we injected the rats with thyroxine, which is T4, and it can be converted into T3. When we injected thyroxine into the normal rat, its metabolic rate went up. That's one of the things that thyroid hormone does. When we injected thyroxine into the thyroidectomized rat, that hormone replaced the rat's missing hormone. It was hormone replacement therapy. And that rat's metabolic rate improved compared to its baseline. When we injected T4 into the hypophysectomized rat, that also helped that rat's metabolic rate. We were essentially replacing a missing hormone in this axis. Then, in the next activity, we injected TSH. Now this invited another layer of learning. TSH, its primary target is the thyroid gland. It stimulates the follicular cells. They get bigger, they mitotically divide. Everything a follicular cell does gets increased, so its function increases. And in some of these rats, when we injected TSH, we found a goiter, which means an enlarged thyroid gland, which can enlarge either from hypertrophy, which means the cells that you already had got bigger, or hyperplasia, which means more mitotic rate. When we have a goiter, both occurs. The rat that was normal and injected with TSH developed a greater metabolic rate, but also a goiter. its thyroid gland was overstimulated by the TSH. The rat that had a thyroidectomy, when we injected TSH, it did not help that rat. Why? There was no primary target for TSH to bind to. Its metabolic rate did not improve, and there was no goiter. Why? There was no thyroid gland for TSH to stimulate. With a hypophysectomized rat, replacing the missing hormone, TSH, helped this rat. Its metabolic rate improved, and it also developed a goiter. Then we used a substance called PTU, propylthiouracil. PTU was not sufficiently talked about in the PhysioEx introduction. PTU blocks proper synthesis of T3 and T4. That part is true that the PhysioEx told you. However, specifically, PTU blocks the iodinase, the enzyme that attaches iodide to the tyrosine residues. If you want to make chocolate chip cookies, but you don't have chocolate chips, but you have all the other ingredients, can you make a cookie? Yep. But is it chocolate chip? No. You can make thyroglobulin. You can exocytose it to the colloid and endocytose it back into the cell and chop it up and release tyrosine residues. But if they're not iodinated, you don't have T3 nor T4. You don't have thyroid hormone. You don't. When PTU was given to the normal rat, its metabolic rate was impaired. And we also saw that when we gave PTU to the thyroidectomized rat, its metabolic rate was low, but not from the PTU. It was from the lack of the thyroid gland. PTU injected into the thyroidectomized rat had no target. It had no additional effect on its metabolic rate. Then, when we injected PTU into the hypophysectomized rat, it also did not alter that rat's metabolic rate because it already had a dysfunctional thyroid gland because it wasn't being signaled correctly. So it was like insult to injury. Did any of those develop a mass? The normal rat? Why do you think it developed a goiter? As its thyroid hormone levels dropped, feedback to the hypothalamus, what would the hypothalamus do? Increase TRH. What would the anterior pituitary do? Increase TSH, and there's your stimulus for the follicular cells. So as you study for your endocrine test tomorrow, I hope you know your feedback loops, your short and your long. Remember, it's the long feedback loop that has the most influence on the system. That's the one that counts the most. And as you study for your lab exam, you should be able to review your data and explain these questions, which I basically just went through. Oops. So that was the system that we were using, injecting those rats. And then we went to activity 2. With activity 2, we were doing a glucose experiment using patient samples. The importance of this activity was just an opportunity to do your spectrophotometer work again. Remember when you did the red dye number 40 and you had to create a standard curve and you had to show that the standard curve obeyed the Lambert-Beer law. If your curve looks like this, that's called a direct linear relationship. That means the Lambert-Beer law was obeyed. But linear could also mean horizontal, could also mean vertical. It could be an inverse relationship. If your standard curve looked like any of those, that was not obeying the Lambert-Beer law, and you could not use the standard curve to interpret your patient samples and their concentrations. So the purpose of this experiment was just to reinforce your spectrophotometer work, review the Lambert-Beer law, and how a standard curve can be used to determine your patient unknown samples. Do not memorize the fasting plasma glucose levels that were given, the ranges of them on page 63. I don't care. You don't need to memorize that. Our focus is the Lambert-Beer law and the importance of the standard curve. Are there any questions for activity 1 and activity 2? Okay. Then, moving on, and Dr. Shaw is just reminding you how glucose management occurs in the body. It is a humoral mechanism, still using negative feedback mechanisms to regulate it. We're going to learn more about glucose regulation in Unit 2 that we're in now. You're going to learn all about diabetes mellitus. Then we went on to, she's still telling you about diabetes mellitus and tests that we use, the fasting blood glucose levels, FPG. There is another test that we use called A1C. And in a future lecture, I'll explain how A1C tests are actually better than a fasting plasma glucose level. I'll tell you how diabetic patients can cheat with the FPG, but they can't cheat with A1C tests. They can't. And I'll teach you why the A1C catches them. And the doctor can say, you're not following your diet. Your blood glucose levels have been elevated. It's a lot similar to, you know you're supposed to floss every day, right? You know that. You've been told that. But do you? Or are you a lot like my kids where the week before your dental cleaning exam, you start flossing? Or the day before? As if that will count all of a sudden. That's how a lot of diabetics are too. Being on their diet is hard, and I'll teach you about that as well. They're going to want to cheat. They're not going to really want to regulate their blood glucose levels and monitor it. And before they have to go into a doctor's visit, they're going to try and show you that they've been good all along. They can't cheat with an A1C. So then, activity 4, we were now looking at the adrenal glands. And we were told on page 67 that these were the following disease states that we were playing with. There were 5. There were 2 that qualified as Cushing's syndrome. One was Cushing's disease. One was Addison's disease, and another one was secondary adrenal insufficiency. When we use doctors' names like Cushing, Addison's, they don't really tell us what the problem is. And we're trying to get away from that, both in physiology and also in anatomy. For example, fallopian tubes. Find the fallopian tubes. That doesn't really tell you where to look. It also doesn't tell you in which gender to look. Not really. But if I say find uterine tubes, probably most of you would be like, okay, I need to find this in a female. Where her uterus would be. Probably you're not going to look around in the thoracic cage for uterine tubes. I would hope not. Don't be my nurse if you do. Cushing's syndrome doesn't really tell us what's going on. It's not very diagnostic. Cushing's disease, a little bit more specific, but still very ambiguous. So I urge you to also look at the words that are in the parentheses. Those are more specific. Those tell you bigger clues where the disconnect is, where the etiology, the source of the problem is. And as we go through your data on the next page, I challenge you. On the next page, our data, we're told, we did the experiment, is the cortisol up or down? Is the ACTH up or down? Here's your challenge. You ready? As I go through those patient samples on the next page, I want you to tell me what the CRH level would be like. And when I asked the early afternoon class, I said, can you do that? Can you tell me the CRH levels for each of those patients? They all do this. Yep. I said, oh, really? They said, yeah, well, we can do that. We've been studying. I said, okay. And they quickly realized, no, they couldn't. We didn't have enough information. We could guess, but we don't have enough information. And I'll prove that to you as we go through. So in the first patient, their cortisol levels were low and ACTH levels were also low. What does this suggest? An under-secreting pituitary issue, right? Hypopituitarism. Okay, how do we know it's the pituitary's fault? How do we know? We don't have a third column, do we, for CRH? Could it be that this problem started with an under-secreting hypothalamic tumor? Could it be that it started with low CRH levels leading to low ACTH levels leading to low cortisol? Could that be a reason? Will we ever know in this PhysioEx? No. Could we find that out in reality? Can we draw blood, send it to the lab, and have them measure the levels of CRH? Yes, we can. Absolutely, we can. So that's why I said to the early afternoon class, so see, you can't tell me definitively what happens to the CRH level. You don't know for sure. You're limited to what the PhysioEx gave us. So is it this person's adrenal glands' fault? Are they faulty? No, the adrenal glands just aren't getting their signal. The ACTH is not where it should be. So this would be considered secondary hypoadrenalism. In the next patient, we had an elevated cortisol and a decreased ACTH. What is this called? Cushing's syndrome. Does it definitively tell us how the patient got this? No, it could be iatrogenic, can't it? Physician-induced. Maybe the person's taking prednisolone, an exogenous cortisol. Or it could be an overactive adrenal gland, over-secreting cortisol. We don't know. It's just categorized as Cushing's syndrome. Next patient, elevated cortisol and elevated ACTH. Based on the options we had on the previous page, this screams Cushing's disease. But could it have started with an over-secreting hypothalamic tumor? Over-secreting CRH, leading to more ACTH, in turn leading to more cortisol? It could have, but we'll never know, will we? We're limited to what the PhysioEx showed us. Patient 4, we had low cortisol, high ACTH. This is high or low. The pituitary is trying to stimulate the adrenal gland, but it's not responding. This screams primary hypoadrenalism, Addison's disease, also known as primary adrenal insufficiency. It's Addison's. And then the last patient, patient 5, is a lot like patient 2. This is hypercortisolism. It's Cushing's syndrome. We're not sure why the person has excess cortisol. It could be physician-induced. It could be an overactive adrenal gland. We don't know. We just know that it goes into the category of Cushing's syndrome. Are there any questions about that? Okay.